and also the WHO Regional Office for Africa. She's coordinated several emergency responses across not just one country, not just 247 different countries. In fact, one notable thing is that she led successful efforts to eradicate the wild form of polio in Nigeria in the year 2020. Thank you, thank you, thank you. Oh, a louder hand clap. And what that means is she's passionate about vaccination, because when you talk about polio, you're talking about vaccination. And she's here with us. She's here to support what we are doing. She's here to speak to us. She's here to inspire us, empower us. And so I would want us to give an overwhelming applause to the WHO Country Director in the person of Dr. Fiona Bracker. Oh, please, you can do better than that. Thank you, thank you, thank you. Can we kindly move forward? Those at the back, please. Let's fill the spaces in front, please. Thank you.
Thank you, Master of Ceremonies, for that introduction. I'm indeed a proud alumni of Makerere University, and I'm also a strong advocate for vaccines. So I'm so delighted to be part of this important workshop. The president of the Pediatric Society of Ghana and our chairperson for this workshop, colleagues from the Ministry of Health and Ghana Health Services, distinguished healthcare professionals, ladies and gentlemen. I am delighted to be here at this very important sensitization workshop as Ghana joins a league of countries in the introduction of the human papillomavirus vaccine to protect the future of girls against cervical cancer. Cervical cancer is the fourth most common cancer globally, with over 600,000 women, new cases diagnosed every year. More than half of these women die from the disease, and alarmingly, 9 out of 10 deaths occur in developing countries. In Ghana, we have approximately 3,000 new cases and about 1,700 deaths that occur due to cervical cancer every year. It is the second most common cancer among women in Ghana. Sadly, over 70% of cervical cancers are diagnosed in advanced stages, and this leads to poor treatment outcomes and devastating financial consequences for families and the health system. This suffering is unacceptable, and it must end, and it can end. The global agenda to eliminate cervical cancer is embodied in the WHO 90-70-90 strategy, which aims to achieve 90% of girls fully vaccinated against HPV by 15 years of age, 70% of women screened at the ages of 35 and 45, and 90% of women with precancerous lesions receiving appropriate treatment by 2030. Ladies and gentlemen, this vaccine, the HPV vaccine, is not new. It has been in use globally for over 15 years. Currently, we have 140 countries globally, including 28 in the WHO African region, that have already introduced the vaccine into their national routine vaccination programs. In Ghana, the pilot introductions of the vaccine in 3 regions, Central, Greater Accra, and Northern regions in 2013 to 2015, confirmed the safety of this vaccine, which aligned with findings from over 160 studies conducted worldwide. So the vaccine is safe. In countries like Ghana, where access to cervical cancer screening and treatment is limited, the vaccine remains a key strategy for elimination. The global community is making progress, and success depends on how we maximize vaccine deployment to achieve high and equitable coverage, while also in parallel strengthening screening and treatment services. Ghana's strategy of delivering the vaccine to girls between 9 to 14 years of age aligns with global recommendations. And this would not only impact the burden of reproductive tract cancers among women, but it would also impact the general population in the long term. Vaccine delivery through national immunization programs, it ensures that we have equitable and sustainable access for all eligible girls, irrespective of where they live and what their social demographic profile is. So, fellow medical professionals, health workers, I would like to acknowledge your efforts in advocating for the inclusion of HPV vaccination in the national immunization schedule. You will all agree with me that the last mile of every journey is often the most challenging one. Our advocacy efforts collectively can only yield the best results if vaccines ultimately get into the arms of those that it is intended to target. You represent trusted voices, and I encourage you to leverage your influence to promote HPV vaccination to the eligible population and the community at large to ensure that Ghana achieves elimination of cervical cancer by 2030. I want to thank the Pediatric Society of Ghana for organizing this sensitization workshop to strengthen advocacy for the vaccine and also to build capacity for all of us to understand better about HPV, about cervical cancer, and the strategies that it will take to eliminate cervical cancer by 2030. Ladies and gentlemen, cervical cancer elimination is within reach, and Ghana is well positioned to win this fight. We as WHO remain steadfast in our support to the government of Ghana in achieving health for all. Let us all unite in support of HPV vaccination. Together, we can protect the health of our girls, women, and secure a brighter future. I thank you all.
Hello, sorry. At this point in time, I'd like to say that, aren't you experiencing and like leadership by women? We are right on time, aren't we? Very crisp, very short, And we have another lady in our midst, a public health specialist, a decade in leadership. If you know her, you know she's very boisterous. She's with the Ghana Health Service. Currently, she serves as the acting program manager for the expanded program on immunization for the Ghana Health Service. She came from the middle belt of Ghana, that's Konfanochi, KNUST. Oh, I thought some would clap their hands, yes. And then she decided to fly to the UK to do Masters in Health Policy Planning and Financing. That's at the London School of Hygiene and Tropical Medicine. She's also a fellow of the Young African Leaders Initiative, alumna of the International Program for Public Health Leadership, and many others. In fact, for those of us in the Ghana Medical Association, we know her very well. She's also one of our leaders. And so this is someone who just likes to get things done. And she's going to be giving us a key word from the Ghana Health Service expanded program on immunization. So please welcome Dr. Salom Kutachi.
Good afternoon. I'd like to start on existing protocols because there are a lot of big men and women here. So I bring you greetings from the expanded program of immunization, Ghana Health Service, and by extension, also my Director General. I'm very happy that we've had this opportunity to do this orientation for health workers. It's something that the program has been looking forward to doing. We've engaged some of the unions privately to see how we could meet them, but PNG came and then helped us tie this whole thing up very well. So I'm quite happy with the work they have done and also the support of WHO for this program to be brought to fruition. Please, let's clap for them. So it's our prayer that from the program that we health workers here would use this opportunity to know more about what we are about to do. We have started quite some engagements. Flyers are out, some jingles have started flying in the airwaves. We are doing radio and TV announcements and interviews and things. But I hope that we'll use this opportunity to be able to know more about what we intend to do. And if you have any questions, we'll answer them. I see my deputy program manager hiding there. He will also help us during the question and answer time. So thank you all very much for making time to join us, both in person and online. And I hope that we'll make very good use of this time and then we'll come out of this program knowing a lot more about the HPV vaccination coming off in October 2025. Thank you.
Another hand clap for Salom. Salom could have also done the GMA one as well. Now we are at the point where we're going to have some direct messages. And like I said, one of our executive members, but she has decided to allow at least one man to do that for us. In the person of Dr. Nana Kwame Kansa, please welcome Dr. Nana Kwame Kansa to give us the message from the Ghana Medical Association.
Thank you. Also standing on existing protocols, distinguished colleagues and friends, on behalf of the Ghana Medical Association, I wish to thank the Pediatric Society of Ghana and all our cherished stakeholders for this workshop on the HPV vaccine. Cervical cancer and HPV-related diseases are preventable, yet they continue to take a heavy toll on our young people. As doctors, we see the impact daily, and we know vaccination is one of the strongest tools we have. The GMA stands in full support of every effort to increase awareness, fight misconceptions, and expand access to the HPV vaccine. Together, we can protect the health and future of Ghana's children and adolescents. Thank you.
So the males are not doing too badly, right? Dr. Kansa, thank you so much. Thank you so much. Now, everyone knows that when you have the GMA, Ghana Medical Association, there is a very strong group that stands right beside us. And they have a very long name. The Ghana Registered Nurses and Midwifery Association, please. Let's welcome the representative, Joyce Mawana Ampao. The nurses are always supportive of every single policy, and they're the ones who make it work. So another round of applause for the nurses representative. Thank you.
Thank you very much. So standing on all existing protocol. In fact, to wear my president's shoe is not easy, but I have to deliver. It's a great pleasure and honor for the Ghana Registered Nurses and Midwife Association, GRNMA, to participate in those sensitization workshops on Ghana HPV vaccine introduction. The HPV vaccine rollout is a great step in the right direction, and I am that the long years of advocacy for national HPV vaccination to protect our future women is finally here. Commendations to the Ministry of Health and all stakeholders who have championed for this in the past. Our shared endeavor at those moments in time is to ensure that the rollout is effective and those that it targets actually receive it. Cervical cancer disease burden has always been high in the Ghana, and the age standardization incidence rates of about 27 per 100,000 women and mortality rates around 16.9 per 100,000 women. The high burden has always been due to late-stage diagnosis due to limited access to effective cervical cancer screening programs, lack of knowledge and education on the early signs of the disease, insistent denial of the disease due to fear and lack of family support system, financial constraints, among many others. HPV vaccination is generally expensive, and just as a small number of Ghanaian women can afford it. It is also a fact that for those who can even afford it, they sometimes have no knowledge about opportunities for screening and vaccination. We must bridge the financial and knowledge gap as a country so that all women who are sexually active can get screened and get vaccinated. This should be our call as a country to protect our women and in the future. The future must not be about our girls and women alone. We must ensure that we vaccinate our boys too, since the vaccination has the capacity to provide lifetime protection against other sexual transmitted diseases caused by other strains of the human papillomavirus. To do this as a country, we need to move faster in developing our own vaccines, not only for HPV, but for other communicable and non-communicable diseases. The future requires that we leave no one behind We must therefore strive to improve the Ghanaian economy, to be better positioned to take care of the health needs of the Ghanaian people and move away from the dependency and over-reliance on foreign aid. The fundamental principle of the UHC requires us to ensure that all people have access to full range of quality health services they need, when and where they need them, without suffering financial hardship. The bottlenecks with our NHIS must be removed to ensure equity. The HPV vaccination introduction must not serve as an avenue of profiteering some people. It must serve the purpose for which it has been introduced. It must serve our girls. On this note, we wish the Pediatric Society of Ghana a successful workshop and look forward for greater achievements together with you. Long live Pediatric Society of Ghana, long live GRNMA, and long live Ghana. Thank you.
Thank you. Thank you. GRNMA will never, ever forget to add long live GRNMA. It always has to come. Am I right? It always has to come. Thank you so much. We're very grateful for the solidarity message. And now, ladies and gentlemen, to the crux of the matter, the heart of today's program, the presentations. Because many of us would have questions. We have adolescents with questions. We'll have mothers with questions. We'll have even the fathers with questions. This is where science is going to meet the story, where expertise is going to meet the experience, and we have people who are going to do justice to that. They're going to talk to us about things that the experience, the evidence available. They're going to address some of our concerns and remind us why today makes and marks a big turning point. Remember, today we're not just talking about science, but we are securing smiles. We're securing smiles, futures, and generations. Prevention is better than cure. But think about this. Prevention is not just about what the vaccine does. It's not just about prevention alone, but it's protection for life, a lifetime. And so, this is the heart of the matter. To kick us, to start us up, sir, are you okay? Are you settled? You're settled. Great. To kick us off, success in policies like this only work with strong commitment, strong policies. And that's where the Ministry of Health comes in. Without policy directions, whatever we do will remain here. So without that, without the support of the Minister of Health, one, as I said earlier, is passionate about this. Remember, the vaccine is expensive. It's been available, but now it's actually going to be part of a program free to our daughters. And to do justice to the Minister of Health in terms of a representative, we have the Chief Director himself of the Ministry of Health in the person of Desmond Boateng, going to give us a word from the minister himself. Please welcome him. Keep clapping. Keep clapping. Thank you, sir.
MC, thank you very much. I was here earlier on at 1 o'clock and the room was empty. So I had to go back to the office and come back again. And that reminds me, well, I think there was a miscommunication, so I think I have to just accept the apology that was given to us by the organizers. I'm here this afternoon to rep our minister. I don't want to say I'm my minister, our minister. And he would have been here himself. But sometimes as a politician, you can be bed 12 a.m., 1 a.m., and then they'll call upon you, come for a meeting and stuff like that. So you have to pack baggage and then move on. So that's how come he's not here with us this afternoon. That notwithstanding, I will proceed to read the speech on his behalf. Distinguished person, chairperson, members of the Pediatric Society of Ghana, representatives of the Ghana Health Service, our partners from the WHO, UNICEF, Gavi, civil society organizations present, distinguished guests, ladies and gentlemen. On behalf of the government of Ghana and the Ministry of Health, I am deeply honored to address this important seminar. Today's gathering takes place at a defining moment in our nation's public health journey. Cervical cancer continues to pose a grave threat to women's health in Ghana, claiming hundreds of preventable lives every year. We know from irrefutable scientific evidence that nearly all cases are linked to persistent infection with high-risk human papillomavirus, which is the HPV. We also know that prevention is within our grasp. The HPV vaccine, when administered before exposure, provides safe, effective, and lasting protection. It is for this reason that from 7th to 11th October, Ghana will embark on a nationwide HPV vaccination campaign, targeting all girls aged between 9 to 14. Thereafter, the vaccine will become a permanent part of our routine immunization program. This historic milestone has been made possible through the unwavering collaboration of the Ministry of Health, the Ghana Health Service, the Pediatric Society of Ghana, WHO, UNICEF, Gavi, and our development and our many development partners. UNICEF has already secured and delivered over 2.5 million doses for the initial campaign, while WHO has supported strategic communication and community mobilization, particularly through the education sector. Ladies and gentlemen, even as we prepare to operationalize the Ghana Medical Trust Fund, popularly known as Mahama Cares, to finance the treatment of non-communicable diseases, particularly cancers, we must recognize that sustainability requires balance. To avoid overburdening the fund, we must invest equally and decisively in preventive measures such as routine screenings and vaccinations. Today's event is a vital step in that direction. Yet, colleagues, the true measure of our success will not be the number of doses delivered, but the level of public confidence we are able to inspire. Across the world, and even here at home, misinformation and myths about vaccines undermine trust and put lives at risk. We must therefore speak with one clear and united voice. The HPV vaccine is safe, it is effective, and it is indispensable to safeguarding the health and the future of Ghana's young girls. To achieve this, we must reach beyond the health sector. Parents, teachers, faith leaders, traditional authorities, and young people themselves must be fully engaged in this effort. Every eligible girl, whether in school or out of school, in our cities or in the most remote rural communities, must be given access to this life-saving protection. By countering myths with facts and by listening respectfully to concerns, we can build the trust and solidarity needed to ensure both high coverage and equity. Together, through effective communication, transparency, and vigilance, we can eliminate cervical cancer as a public health problem in Ghana, and in line with the World Health Organization's global strategy. On behalf of the government of Ghana, I wish to commend the Pediatric Society of Ghana and all our partners for their vision, leadership, and dedication. Let us leave this seminar united in purpose and resolute in action, determined to consign cervical cancer to history. Thank you, and may God bless our homeland, Ghana.
Please, let's give him a round of applause. He's the person going to make it happen. So give him another round of applause. Do that for your daughters. Do that for your sisters. I was going to say mothers, but they are maybe future mothers. Yes, we are going to please continue. We have another solidarity message from the Ghana Association of Public Health Technical Officers, who will be actually doing the vaccination on behalf of the Ministry of Health. Let's welcome Richard Asian. Mr. Richard Asian, please. Thank you.
Thank you very much. I'll stand on the existing protocol, and also on behalf of GAFTO, show our appreciation to the Pediatric Society of Ghana for this very, very important initiative. I want to indicate that vaccines remain the most efficient tool when it comes to disease control and prevention. And we want to use this opportunity to call on all stakeholders to come on board to ensure that this exercise becomes successful when it comes to the HPV vaccination and vaccinations in general in this country. The beauty of the whole thing is that we are going to also routinize this beyond the campaign, and we all need to embrace this very, very milestone. As an association, I want to pledge on behalf of GAFTO and indicate that we are ready, our men and women, to support this process at all levels of the service delivery, right from the national level, the regional level, district, and then the sub-district level. Typically in the area of proper vaccine management, demand generation activities, in safety monitoring, very important. And for such a campaign like this, data management, so we can speak to it in future, and the coordination of this exercise. Personally, I'm happy because my daughter will be part of the campaign, and I would like to call on all parents, all stakeholders, that we need to come together and support this cause for a successful HPV vaccination come the 7th to 11th of October 2025, and the routinization. Thank you very much for your attention.
Thank you very much. Thank you very much. We're just going, as a short interlude, we're just going to have the dignitaries come forward, please, so that we take a snapshot. Nowadays, it's about Instagram. It's about TikTok. Are you going to put it on TikTok? Maybe, right? Yeah, So the dignitaries, please. So dignitaries, where are they standing? And then can we also have the presenters as well, please? Presenters, please, yes. So dignitaries and presenters. Okay. Please, we haven't closed yet. They're just going to take the photographs. They want better lighting. Sometimes I wonder, everyone keeps talking about standing on existing protocols. By the time we get to my turn, the protocols would have broken down. But let me share a few questions that should push your mind, so that when we are listening to the presentations, because these were some of the questions that some people have in mind, so that as we are sensitized, we can speak with some level of authority, some level of understanding. So for some health workers, some questions were, how safe is the HPV vaccine? You've heard of a lot of, if you listen to CNN or watch CNN, there's always this anti-vaccine group. Some questions are, what are the side effects? Usually for adults, we're okay. For the little babies, we're okay. But for the adolescents, that we start getting a little concerned. So let's consider that. Some other questions were the age. So let's take note of the ages. And what about those who are not in that age group? What happens to them? How do we handle vaccine hesitancy? And believe you me, here in Ghana, I know parents who have refused to have their children vaccinated. And these are well-educated individuals. So it is something to consider. Again, what's the guidance for boys? How are they going to benefit? And then some questions that came up again was for parents and caregivers. Once they've had the vaccine, do they need to be screened? Because generally when we are speaking to ladies, we tell them about pap smear, isn't it? I'm a pediatrician, so is that what we say? We talk about pap smear, isn't it, for the ladies? Yes. So these are some of the things. So are they going to have to be screened later? So these are some of the things that we need to pay attention to. Will it affect fertility? Some have concerns about fertility. The children are supposedly not sexually active, even though I did a research some time back and found out that they were sexually active as early as 8 years. As 8 years, yes. So we need to consider that. And then for the adolescent patients, is it painful? Will I feel sick? Will I be able to attend the party if I have the injection now? They would ask. So as we head into the next session, the presentation section, please let's ponder about this question some people have already raised so that we're well informed as we speak to all those. Again, just so that we know, the toilets, the washrooms are, when you go out to the left, you find the washrooms. I've been talking, I was expecting that our distinguished guests would be back. They're not back, they're still. Oh, we can go ahead. Okay, right, okay, thank you. All right. So, we're moving into the presentation, and I believe we're still on time. To kick off the presentation, we're going to have a distinguished specialist obstetrician gynecologist, which I'll say OBGY from henceforth. It's a mouthful. And she's with the University of Ghana Medical Center. And not only does she take care of ladies and pregnant women, she decided that she is particularly concerned about gynecological cancers. And so she's an expert in the area. She went all the way to University of Cape Town to study just that, oncology, only about women, only. I've known her for more than a decade, and she's nothing short of unconventional. She's brilliant. And when I say unconventional, you would know that OBGY is mainly a male-dominated area here in Ghana, but she has actually pushed through and she's doing well. She actually wants to establish her own oncology center. We'll support you. Oh, give her a round of applause. Yes. She has compassion for patients. She's relentless in her advocacy for antenatal care, maternal health, and cancer prevention. In every sense, she's a trailblazer. She saves lives with both expertise and empathy. Let's welcome Dr. Amma Ghani for the first presentation.
Good afternoon. I am honored to be here, and thank you, boss, for that flowering introduction. So I'm giving a presentation on HPV and cervical cancer, why vaccination matters. This is the outline of my presentation, which I cannot read now, so please let's move on. So every 2 minutes, a woman dies from cervical cancer worldwide, meaning in this 15 minutes presentation, 7 women are going to die. That's 7 mothers, 7 daughters, 7 wives, 7 breadwinners. I hope that will sink in. What is HPV? The human papillomavirus. It's a common sexually transmitted infection. I say to my patients that catching it is as easy as catching a cold. There are over 200 types and at least 12 are high risk. Most patients will clear the infection spontaneously. So once a woman starts having sex, 80% of these women would contract HPV. Most of them will never know because 90% of these women will clear spontaneously HPV. The 10% who will not will have risk factors that we'll mention later on. Please move on. So HPV causes about more than 95% of cases of cervical cancer. Some literature says up to 99.7% of cases are caused by high-risk HPV. And HPV 16 and 18 are high-risk types that cause about 71% of cervical cancers. HPV is also linked to cancers of the anus, of the vulva, vagina, penis, and oropharynx. What's the burden of cervical cancer? So in 2022, there were over 660,000 new cases and over 340,000 deaths. This is according to Globocan. And about 85% of cases and 90% of deaths occurred in low middle income countries. And it's a leading cause of cancer deaths amongst African women. So risk factors: low socioeconomic status or poverty is a major risk factor. Another is persistent HPV infection, high-risk sexual behavior. What we mean by this is a girl or a woman who starts having sex at a very young age, a woman or girl who has multiple sexual partners, a girl or woman who has a high-risk sexual partner. So that's a sexual partner who has multiple sexual partners. Sometimes you cannot control that. There's also HIV and immunosuppression and other immunosuppressive drugs like steroids, women who are on anti-transplant rejection medication, women who smoke, and also lack of screening and vaccination. These are all risk factors. Prevention is possible. So in the year 2020, WHO came up with a global strategy to accelerate the elimination of cervical cancer as a public health problem. And it was a three-pronged approach. So by 2030, the aim is that 90% of all girls below the age of 15 or by the age of 15 should be vaccinated against HPV worldwide. And by 2030, 70% of all women should be screened by high performance tests by age 35 years and again by age 45 years. And then 90% of all women who have a pre-cancer or cancer should have access to treatment by year 2030. And if we are able to meet this target, then we are aiming to reduce the incidence to 4 or less, 4 per 100,000 women years. HPV vaccination is safe, and we know they are effective vaccines. They've been around since 2006. In 2006, America first introduced the HPV vaccination. We have the bivalent vaccine like Cervarix, quadrivalent vaccine like the Gardasil 4, and then a non-valent vaccine like Gardasil 9. And they all protect against HPV 16 and 18, which cause about 70% of cervical cancers. And it's best that boys and girls receive the vaccine before sexual debut. So usually we aim at the age range 9 to 14 years. The benefits of vaccination. Vaccination prevents HPV infections. It prevents the precancerous lesion. Vaccination provides herd immunity with high coverage. If you're able to cover a large number of girls, then we expect that even those who are not vaccinated obtain some level of protection from HPV. And then it also provides long-lasting immunity. Studies have shown that for at least 10 years and possibly longer, girls who have received the HPV vaccine are immune to high-risk HPV and persistent high-risk infection. So what's the global progress? More than 140 countries at last count have introduced the HPV vaccine, which is impressive. And these countries have noticed declines in HPV infections and cervical precancers. You talk about Australia, you talk about Norway, New Zealand. They are doing very well because of a combination of vaccination and then screening. What challenges do we face in low middle income countries? There's a problem of high vaccine cost and limited supply. Then we have the myths and misinformation. We have some countries have weak health systems, and then there's low coverage as well. So let's talk about the Ghana picture. In Ghana, is the second commonest cancer in the Ghanaian woman, is also the second common cause of cancer-related deaths in Ghana. In 2022, we had over 3,000 new cases and 1,800 deaths, meaning that if you have cervical cancer in Ghana, there's a 60% chance that you are going to die from it. So what is the problem? We know what causes cervical cancer, that's HPV. We know that there is a precancerous stage that we can pick up by screening. We have recognized screening tests, some of which are high performance screening tests. And we know that we can easily treat these precancerous stages and prevent them from developing cancer. So why are women, 6 out of 10 of them, still dying from cervical cancer? The simple reason is that they present very late. Most cases present at an advanced stage in Ghana. There's a study done by Dr. Edouard-Pierre Kubi et al., and they interviewed 100 women with cancer, and only 8% of these women had even heard about HPV. So how would they even screen? Let's talk about the WHO's global strategy for eliminating cervical cancer. If you talk tertiary prevention, what's the picture in Ghana? We have less than 10 gynecological oncologists who operate on women with cervical cancer in the whole country, in a country of a population of almost 35 million. We have just a handful of radiation oncologists. We have less than 10 palliative care oncologists, and these are all supposed to contribute to the third prong, the 90% of patients who are supposed to receive care. We have only 3 centers in the whole country that can offer radiotherapy. And remember, most of our cases present late, so they will need radiotherapy. There are 2 centers in Accra, 1 in Kumasi. So if you don't live in either of these cities, you have to travel. Let's talk about secondary prevention. 70% of women should be screened with a high performance test. Women don't even know about HPV, so awareness is low. They don't know about screening. And even if they did know, we don't, as at yet, have a national cervical cancer screening program. But what do we have? We have the HPV vaccine that's about to be rolled out next month, which we are all very grateful for. If we are able to effectively roll out HPV vaccination and vaccinate about 90% of our women or our girls, then they do not get the persistent HPV infection. They don't get pre-cancer, they don't get cancer, and they don't have to be treated. So why does vaccination matter? Vaccination will save Ghanaian lives, or everyone's lives, women's lives, actually families, because families depend on women heavily. Vaccination will prevent suffering as well. If you've ever seen a woman with late-stage cervical cancer, it's heartbreaking. They go through a lot of pain before the end. Cervical cancer vaccination will reduce future healthcare costs. They don't have to develop cervical cancer and have to travel for radiotherapy or surgery. And it also supports the WHO's 90-70-90 elimination goal. So what can we do as we leave this conference room? Let's support the HPV vaccination program. Let's tell all of our social networks about the vaccination program. Let's educate to fight myths. One of the speakers will be talking to us about some of the myths. Let's listen attentively and try and disabuse others about some of these myths. Let's try eventually to combine vaccination with proper screening and treatment. I think a world without cervical cancer is possible, and Ghana is about to take the first step. Thank you very much.
Thank you very much. We would have a point in time in the program where we would have questions. So if you have any questions, you could jot them down. You have papers, you have pens on your table. You can jot them down for that time. We're going to quickly move on to our next presentation. When you're talking about myths, you need someone who actually has a professorship in this. This one is the genuine one. It's not the one you buy. We have Professor Anthony Enemel, one of my mentors, teachers. Oh, boss, you're not going to hurry up here. He's a fellow of both colleges, West African and Ghana colleges, an associate professor of pediatrics, and he's the head of pediatrics infectious disease. Oh, boss, now continue. His career spans medical education, research in, and thank you very much.
Thank you. Yeah, he's a lovely brother, and we always love him when he's emceeing. Can I have my slides, please? Thanks for this opportunity. I'm grateful to the organizers, especially our president, who personally called me. And who am I to say I won't come when the president calls you? You have to heed to the president's call. Next slide. So within my 15 minutes, we'll look at the objective for this presentation. The key message, which I've put it in a summary, we look at the definition, myth, misconceptions, and the way forward. So by the end of this presentation, participants should gain knowledge on common myths and misconceptions regarding HPV vaccines. And most of the examples are within the studies done in Ghana. The strategies to address the above, and also we'll share some experiences. So these are the information I want you to take home about myth and misconceptions. Let's speak to facts, because we are scientists. We know the truth, and let's not propagate fiction. Sometimes we add lies when we don't want the patient to be, let's speak to facts when it comes to HPV. We need to look at benefits above risks, because again, in the community, they are looking at risks against benefits. And so long as they look at risks, the more we tend to lose. But there are more benefits than risks. We look at the public health approach than individualized approach. Let's look at teamwork above division, research above speculation, and in quotes, spirituality. This must guide our steps to demystify myths and misconceptions regarding HPV. Next. So these are definitions which we know. A myth is an often traditional story that may explain some aspects of natural or social world. And if you listen to the TV and radio stations in Ghana, you understand this better. A misconception is false or inaccurate idea that is based on faulty thinking, flawed understanding, or misinformation. Next. So there's a quotation that lack of knowledge, my people perish. Some of our mothers are perishing because they don't have the knowledge. So there's a lack of awareness of the availability of 55% of Ghanaians did not have understanding that cervical cancer, there was a vaccine to prevent. And also in a study, later you can look at the reference, there was lack of awareness of HPV vaccine in 95.9% of women who were interviewed. So we are looking at some of the myths. HPV vaccine causes serious side effects, as Ahmad spoke about. These are some of the mentality within the public that it can cause infertility. It can lead to ovarian failure, can lead to autoimmune disease and cancers. I mean, the vaccine themselves can cause cancers. And so if this is the way I think, I'm not going to take the vaccine. Next slide. HPV only affects sexually active individuals. So many, even including health professionals, believe only sexually active women or girls are at risk. HPV can be transmitted through non-sexual means, and studies have been done to show that even in boarding schools, using of toilet facilities can transmit. And there was a study which was done by one of our active GMA members, IFA, HPV specialist, and actually they screened nuns, sisters, who per principle we know they are not sexually active because they are married to our Lord Jesus Christ. Yet some of them had the strains that can lead to cancer. Next. Next slide, please. Yes, so HPV vaccination is only for females. And as one of our speakers said, men who give it to the women must also be vaccinated. So HPV is actually initially targeted primarily at females. And most of the time it is because of logistics and funding. But universally, it is now recommended for all gender to prevent HPV-related cancer effectively. So the idea that the men must not be vaccinated, well, I'm sure it's just because of funding and logistic reasons. Otherwise, The young men who are giving it to our women, when they are protected, they won't transmit it to the women. Next. False perception of vaccine impact on sexual behavior. Some believe HPV vaccination leads to early or promiscuous sexual activity. Again, that is in the minds of some parents. So this is not mainly from the child point of view, but the parents who, for one reason or the other, think they brought up their girl to be cautious in even entering into relation. Some will not agree because they think now you are introducing them to a vaccine that will let rather them going to chase boys. So scientific studies consistently find no link between HPV vaccination and changes in sexual behavior among recipients. Next slide. Cervical cancer can't be prevented by vaccines. Again, there's a misconception out there that in some studies, low awareness of the link between HPV and cervical cancer. And again, 80% did not know about HPV vaccines. And this study was done in some population in Ghana. And I'm sure our activity here is really telling us that there is a way of preventing through vaccine. So let's go out into the community and let them know there's a vaccine to prevent cervical cancer. Vaccination is unnecessary if there are no symptoms. And again, this is quite common traditionally among Ghanaians. We will never go for checkup because menyare. And that is even beyond cervical cancer. People would never, 3 years, we will not go because, well, I don't have a headache, why should I go? It's the same principle here, including the idea that HPV vaccination is only needed after symptoms or sexual debut. And so if we don't desensitize parents and children, well, they think they are virgins, they don't need this. But we all know that the target is especially for people before they start, girls especially. Cultural and religious misconception, misinterpretation of religious texts. Sometimes in some religions we quote scripture or teaching can lead to the rejection of vaccine based on moral objections or believe that the vaccine is unnatural. And I'm sure you all follow the spirit, the COVID-19, how Bill Gates was linked with depopulating Africans, why we shouldn't take the vaccine because it's a conspiracy. I heard that a church says they are covered by the blood of Jesus. So why do you go for vaccine? And so we are here to correct all those. It is just misinterpretation of the word. And these are what is happening. Next. So look at the approach, general approach to which we know, but we just need to enhance. So community education and outreach approaches. And I know as health workers we do that, but community is community. Community of students, community of SHS students, church community, rural community, urban community. Let us identify groups and have customized education initiatives to help address specific community concerns. And remember, depending on the traditional area you are coming from, the details may be different, but you still need to tailor messages to suit the population you are dealing with and make meaningful impact. Again, engaging communities, active community involvement enhances truth and acceptance of HPV vaccination, especially when it's coming from health workers. And remember, we all stay in communities. Let's begin to use our own community as the first point of information. I'm sure in your community, you might be surrounded by non-medics. Let's begin to make impact because they respect you. They know you are a doctor. Have you tried even along your line, people you stay with? That is, apart from those of us staying in doctors' flats, surrounded by only doctors. Some of us are staying in communities. Let's make the impact. Improve vaccination understanding and use the story of the EPI vaccination. Most mothers attest to the wonders that is doing, and just tell them this is an add-on to make it better. Move, next slide. Role of healthcare providers and local leaders, chiefs, imams, our pastors, our deacons, our bishops, our archbishops, they are all there. When they stand in the pulpit, wherever we find ourselves, let us speak to them. Pastor, today, can you give us 2 minutes as health workers in the church to speak about something considering the women? Generally, in every denomination, there are more women than men, true or false? Yes, so, and it is about preventing our mothers from getting cervical cancer. Again, accurate information dissemination. It is important for us to give the right information. Tell the truth. Give the facts. Yes, the vaccine may cause pain, right? But the benefits after the pain, which is temporary, far exceeds the small pain you will get. So explain it to them and use past examples to tell them that it is good. The second point, local leaders and healthcare professionals share reliable information to counter misinformation. I'm sure we'll do that later, give opportunity for people to express some of the information they have. They will correct them. Building community trust is important. I've spoken about that already. Using ourselves as healthcare role model players. Next. Collaboration with healthcare professionals. Again, most of us here are in the health, but we have significant numbers in education, significant numbers in other specialties, not necessarily health. But let's partner with them. And I know Pediatric Society is involved in a lot of outreaches, and give the message. Tell them the truth, not the myth. Don't emphasize what is not right. Consistent health messaging. Collaboration ensures uniform communication. Let's speak the same language, reinforcing vaccine benefits and safety over the other things which we know we are not true. Professional endorsement is important. Sometimes you see some adverts, GMA, Pediatric Society endorses it. Once people know HPV is endorsed by Pediatric Society, they will allow our adolescents to go for it. And I guess that is the reason why we are leading this advocacy. Next. So utilizing media and public campaigns, and under I've written differentiated service delivery. We know people are on WhatsApp, youth, some are on Instagram, they don't like WhatsApp because they think we are there. They want things that are where they want to go. So notice where they want to be, especially the youth, and track them with messages. They have no choice but to watch Instagram. Yes, I just do WhatsApp mainly, so you won't get me on the other platform because it will overload my schedule. But the youth, they like them. Some names, I'm sure if I ask the young lady there, she will mention some to me. Let's know that and create messages, content to suit what they want, and let them learn at an early stage. Again, in the print media, newspaper, so target as much as you can and let everybody has an opportunity. Next. So building trust through transparent communication, honest dialogue. I've actually mentioned this already. Mention the risks and benefit, explain it to them very well. Encourage informed choices. Let them know why they must take the vaccine. Don't just coerce them. We can build evidence to show that it is important from public health perspective to take the vaccine. Next. Strategies for effective community outreach. Again, let's have targeted workshops, know the type of information depending on their population. Informational materials, have leaflets, share it with them, use diagrams and let them appreciate the information. Culturally sensitive communication is important. Remember, there are cultures that forbid certain terminologies. Know how to go around them and use what is accepted based on the population you are dealing with and the community. Next. So religious matters comes in because Ghana is highly religious. So open, respect, dialogue. Engaging communities through respective conversation promotes understanding and address vaccine. Even within our churches, they have a lot of respect for health workers. So engage the leaders, engage them and tell them and explain to them. Let the leaders buy into the idea. And they are the ones who give you opportunity to speak to their congregation. Even in so-called camps where they take them somewhere, if you approach the leaders and you really explain things to them, they will begin to understand that it is necessary. Clarifying misconceptions. Clarifying moral and health misconception reassures communities about vaccines, safety, and intent. And often it is because when we don't give the message right that they tend to rebel. Most of them are willing to listen if you really go down and speak to them and then give them the respect they are due. Don't go and condemn them. They will rebel. And often when they rebel with their congregation. Next. Facilitating dialogue within faith, the role of faith leaders. We can reduce stigma effectively by putting the right information across, fostering supportive attitude, faith-based discussions, encourage positive attitude towards vaccine and health practices. So it's all about engaging them and telling them the need for that. Importantly, let's get cancer survivors to be advocates. They should share their personal stories and their journey. I mean, if you give them or tell them the need to come from a public health approach, they will be willing to do that. And also they have support, immediate family, spouses. Let them share some of their experiences and how they have overcome. Because that would be lessons for others fighting cervical cancer, especially the support. Sharing preventive strategies for her loved ones to avoid her predicament. Remember, they are the best people to tell their children, go for the vaccine, because this is what I've gone through, and it will be of benefit. Next. So in conclusion, our take-home message, I'm revisiting what I stated. So far as we are here, we are knowledgeable. Let's go with facts above fiction, because sometimes we buy into fiction. It's not true, but we want to massage the message. Let the facts be there, but keep speaking and get them convinced. Benefits above risks. Let's look at the public health above individuals, research above speculation or spirituality. Let's have teamwork. Work together, health workers, community advocates. These must guide our steps to demystify myths and misconceptions regarding HPV vaccines. Thank you. Stand by for questions.
Thank you, Prof. Because of time, thank you. Because of time, I'm going to quickly introduce the next speaker, Dr. Henry Nagai. He's a public health physician of 25 years of global health experience, ranging from HIV, viral hemorrhagic fevers to immunization. He's led many programs. He has been with the Ghana AIDS Commission, UN AIDS. His work has actually shaped national HIV vaccination policies. And he wants to cut this introduction brief. But today he's going to be speaking on the role of healthcare workers in HPV vaccination advocacy. So ladies and gentlemen, Dr. Henry Nagai.
Thank you very much. And it's a great pleasure to be here. It's been a long journey. And well, as I said, all protocols observed, but sometimes you can see this is very, very short. So I'm going to start with 3-point story. I had to deal with my daughter who was outside the country and had the vaccine. And then when she came back, the junior brother, for some reason, read about everything, and came and was asking me. He is 13 and was asking why we allowed the day to have the vaccine and he is not. That I said, oh, I'll explain later on. Went ahead and read more and asked more questions. And we had no option than to make sure that he can also get the vaccine. You can't hide things from Gen Z. You cannot. The second story is I come from Greater Accra region, from the previous Dangbe West district, which is now Shire Osuduku district. It is one of the districts that had the cervical cancer the vaccine pilot, Dr. Tanko, in the past, 2013. And I was then a young clinician with FHI 360. I was a clinical officer and one of the clinical trial monitors with Navrongo. I mean, we did the Gadasi bioequivalent trial here in Ghana. And when the vaccine was being rolled out, people would call, is this thing safe and all that? And recently, I visited, and you can imagine 2013, 14, some of them are in their 20s, and they've had their kids, 2, 3, those who are doing other things and are not in education, etc. That tells me that the vaccine doesn't prevent people from, having, if anything, it helps them to be better in terms of facility. Then the last one, which for me is very important, is I remember we were at the Kempinski Hotel and we were dealing with developing the roadmap for Ghana to become self-sufficient in immunization financing. And there was a lot of discussions. Since 2014, as I work in the development sector, we try every time to, you know how Gavi works? You have to look at the GMP and then the GDP. And then when we see that your country, you are improving in your figures, then we say, okay, you can take care of yourself. So what? Exit. But we've been trying every time not to exit. It's like you are in a training program, a school. And then when it's time for you to graduate, you beg the professors, Professor Anime, you see, because of this, I don't want to graduate. That has been this day. And that day, Dr. Tanko, and I'm sure Dr. Kuchiati and those who have been in vaccine mind, there was this modeling we did. When they added that of HPV vaccine to looking at co-financing and how much government is supposed to pay, the whole thing became completely off. The amount, the resource was so high that we were like, oh, okay, so now let's backtrack onto it. But what I'm trying to say on this last story is that the government has done very well. It's a good decision that they've taken to take on the HPV vaccine, at least for the campaign now. And one of the questions before I continue is to ask Dr. Selom, Dr. Kuchuati, if she's ready with the money to continue the routine, to integrate and continue the routine. I'm sure she will respond to it. But we have the campaign. Next slide. Good, the next slide. Next slide. These are some disclosures I had to. Yeah. So I would like that, because we are healthcare workers, I reach you this presentation to focus on certain things that will enable us to think through. Because as healthcare workers, we need to be empowered. As was said by both Dr. Gan and Prof. Enimil. We need to be empowered. If anything has taught us lesson in the past, it's a healthcare worker who doesn't understand the science, who is just going around and saying something. We learned that in COVID. Yesterday, I was on another program with the International Pediatric Association President, Taka. I told him about you, Hilda. And one of the things is that we should not assume that healthcare workers have the requisite information about these vaccines. We need to grasp the basic science and have the broad knowledge. Then we can use it to support the and the government's actions. If we don't know the science, we get confused or we support the myths. And I can tell you later on story about the GMA famous 7, you know, those who signed that we shouldn't have the COVID, because I was engaged in one of the conversations with them. So we need to grasp the science behind this. We mentioned that cervical cancer has an infectious etiology. We also established, and I'll go through this quickly because we also established that there are at least 12, 14 types that can cause this. Now, take note of this fact, because when it comes to implications as to whether we should continue to screen or not, we need as healthcare workers to understand why we should be continuing to screen because of some of these issues. We also established that it is skin to skin and skin to mucosa. I remember in Kenya, and I've worked with JS as well, in Kenya, in even Nigeria, we have about 12 million girls already on you see, Ethiopia and others. A lot of people ask, is it transmitted through blood? No, because they connect it to HIV and all that. Skin to mucosa, that's why it is there. And then we currently have 6 prophylactic vaccines that are available. Now, all HPV vaccines, the vaccines we have protect against serotypes 16 and 18 that cause up to about 70% of the cancers globally. This is very important because whichever country you are in, whether you be doing the bivalent, which is for 16 and 18, or the quadrivalent, which is 6, 11, 16, and 18, or the nonavalent that had the rest, you still have good level of protection for 70% of cancers. Another thing is that all are indicated for use in females 9 and older. Now, we need to understand these broad ideas. And then when we come to our situation in Ghana, we know that because we are in Ghana and because of some reason and whatever it is, that's why we have decided to go this particular direction. Because when we don't have this understanding, the Gen Zs who are reading, like my son, will come and question us and ask us all kinds of questions. Anything you tell them, they Google, they go to AI and they check. Okay, when the AI is hallucinating, you can deceive them, bro. But you know, so let's be clear about that. I know that some are also licensed for use in males. You know, next slide. Now, this is very important. So the serotypes that we have that are causing the over 12 to 14 serotypes, there are a couple of them that there are vaccines against. Serotype 6 and 11 cause 90% of genital warts. And those of us who have been in HIV for some time, we know that this is very problematic when it comes to women living with HIV. Serotype 16 and 18, as I said, 70%. Now, serotypes 31, 33, 45, 52 cause about 10 to 20%. And there is a very important reason I'll bring about in the next slide. But I want us to appreciate this as healthcare workers who have deeper knowledge so they can speak to the issues. So when you look at the bivalent vaccine, that is for 16 and 18. Some countries, they just have the bivalent vaccine. Shekolin or any of them, there's a Chinese type that has come. Some have the quadrivalent vaccine, which I think, Salom, Dr. Akuzi, I'm sure we are using the quadrivalent, isn't it? Yeah. So this is 16, 18, 16, 11, 18, 16 and 18, 6, 11, 16 and 18. And that is great. Some countries have only bivalent. Okay, and then we have the nonavalent, which have this. It is important to keep this in mind because, next slide. The last time I joined, and I do this a lot, if you are a public health scientist, we can jump into anything. So I joined a discussion by our oncologists from one of the universities. They had a link, so I joined, and they were discussing cervical cancer and some of the issues at the treatment level and etc. And they had a big concern about serotype 35. If you go back to the previous slide. When you look at the vaccines that we have, it doesn't cover serotype 35. Next slide. They had a big concern about serotype 35. These are scientists, these are oncologists who are in the treatment area. And they were not happy, and they had conversations, both supportive and others were like, so who are the people who have been bringing in the vaccine and they didn't know that serotype 35 can cause, I'm a clinician, so when clinicians are talking, they are not public health people, they are not in vaccines like myself, and so I had to then come in there. These are our oncologists, and they were right. Serotype 35, there's no direct specific vaccine for serotype 35, either in the bivalent, quadrivalent, or nonavalent. And in sub-Saharan Africa, when you look at the permutations, where we said 70, and then the rest will cause 10 to 20, so around 10% there about the rest, including 35. And 35 in particular is known to cause high-grade precancerous lesions in Black women of Black ancestry. Okay, no specific vaccine has been developed for 35. What it means is that even if we have the vaccine that we have, which is great, we still need to continue to do what? Screen. And that is why we don't have to say somebody have had sex, so he shouldn't have the vaccine. If he's transmitting and he has another serotype, what are you going to do? So those who have qualified or have the money should have the vaccine. Next slide. So, and there was a big question. So they asked me, and this is not only here, I just came back from Asia. They asked this question. So why didn't we have 35 in the seat? The truth is this, and we as healthcare workers have to appreciate this because it can lead to all kinds of myths among scientists and all kinds of misconceptions, etc. We are not ordinary people. We are healthcare workers who have a deeper understanding. What is happening is that it was not a priority in the initial vaccines because of the low global prevalence. Secondly, when things are starting, it starts with the problems that they have first, isn't it? Yes, and we know that in Africa, we are trying now, thank COVID, to have centers that are evolving. Kenya is doing its first pneumococcal vaccine trial as we speak. Okay, yes, I will go fast. So I just want to make sure that the rest of the things I'm going to say are ordinary, but as care workers, we appreciate these matters. Remember this, when we have Gardasil, when we have the quadrivalent, or in this case Gardasil 4, there is some cross protection against 35, especially sublinear A2, I think. But it is not perfect, but there's some cross protection. We need to appreciate this because it will come up to us as healthcare workers. Next slide. So this has been said already. The primary target population, and I'm speaking generally from the WHO and other sectors, is 9 to 14. Remember, secondary targets, we have those greater than 15 years. then boys or older males, or MSM as we call it, to prevent HPV cancers and what. This comes up in every country that we have had opportunity to support introduction of HPV vaccine. The confusion about only girls and not boys, and whether when you are more than 15 years, you can have it or not. We know 9 to 26 years, yes, you can do that. After that, it depends on the agreement with the healthcare provider. We need to have this knowledge so that if somebody wants to take the vaccine outside what the government is able to provide in the public sector, that individual should know why he's taking the decision and why, and why he has to go in that direction. Next slide. So let's come to healthcare workers. There are groups that influence parents, but healthcare workers are the biggest influences. The ministries, Ghana Health Service, child, private services, the schools, religious institutions have been said already. Next slide. Healthcare workers are trusted messengers. And I'm quoting some of the papers that we read. Parents trust healthcare providers. So when the doctor tells me something related to my child health, I trust him. Next slide. Healthcare workers, we must frame HPV vaccination as a cancer prevention. When we are talking to patients or clients or customers, it is important, and I'm speaking from the lessons and the literature and all that, we must frame HPV vaccination as a cancer prevention and lead with HPV vaccination helps prevent cervical cancer. We must lead the conversation that way. We should be able to share that HPV is a very common virus that causes almost all cervical cancers. We must be very clear and direct with our communication. Next slide. Second, apart from framing it that way, second, we must help to normalize HPV vaccination. You know something that is happening in Ghana? There are people, including those in my area, who think that HPV vaccination is an exotic thing. It's for the rich kids. That's because of the cost in the private sector, if it is not available, etc. So there's that perception. So we should tell people that HPV vaccine is recommended and it's part of their adolescent health package. Messages that we found useful in other countries is like, your child is 9 years old and is supposed to have the vaccine. It is available. Please go for it. They trust us and they will act. I've spoken about the last point already. Next slide. The other thing is what we call aspirational framing. Make sure that the message to the parent who has come to the facility is aligned with the parents' hopes for the future of their kids. No parent would like the daughter to have problems in future. Okay, and then you help them to pledge to get their daughters 1 dose, or at least, or 2 doses. Please remember this, and I know that the program will be talking about this. Young people living with HIV will need 2 doses. The dose we are using for Ghana, as determined by protocol, is a single dose. But young people, 9 to 14, who are living with HIV, and Dr. Enemil is looking at me because of the young PL-HIV groups that we have. They will need 2 doses. We should be knowledgeable about this to talk about it. Next. As healthcare workers, we should repeat positive messages, not misinformation. Because when we are knowledgeable enough deeply with what we have just looked at, we shouldn't repeat misinformation. We should positively frame the facts. HPV vaccination can protect girls' future fertility. Rather than HPV vaccination doesn't cause fertility problems. Now, these are researched and have been used in messaging across different countries. Okay, and we must try not to repeat myths to debunk the same things. We must repeat positive messages. Next slide. Make action easy for the parents. Let's make sure that things are easy. Clear, confident messaging. Of course, we know we have to avoid technical jargons and unusual acronyms. Some of the acronyms, they know. HPV or HIV or whatever it is. But let's be. And then we should also include a clear call to action. This is very important, colleagues, in terms of where, when, and how she can get the vaccine for the daughter. The last but not the least, this is not a workshop for that, but there's what we call motivational interviewing. I'm sure some of you might be familiar with it. If you are not, I will recommend that you get the, maybe I'll share the link, and then go through that process. Because most pediatricians go through that training. It's a very important technical tool. Because when you have that skill, it helps a lot. We went through the training some years ago, and it has helped in anywhere I see to look at vaccine issues. Next slide. Please, this we've seen in Ethiopia, we've seen it in Kenya, I was in Malawi, and yesterday in that discussion, you know, Pakistan, Ghana, and India are those introducing the vaccine around this time. This issue of trypanophobia, you know, fear of needles, is something that we have to be aware of. And the simple thing that has been known to help these teenagers is just telling them to, and then our pediatricians know it. Turn your face away and then you get the jab. You know, and asking them to wait the 10 to 15 minutes, you know, because in the previous 2006, HPV vaccine was introduced. And there were a whole lot of things. Some of them were due to the hysteria, was due to people who were anxious and because of the fear of needles, etc. Okay? So beware, so you take care of them. Now, I'm making sure that we can deepen our knowledge around these and make sure that we read more around it. And as healthcare workers, we are confident and competent enough to make sure we can meet the needs of this. And it's based on our own African experiences of places where the vaccines was introduced. Next slide. I think this is the last but one. There's this growing group within the public health community who deal with climate and health, and we call it courageous clinicians. Be a courageous clinician. Use every opportunity. It's a war against cervical cancer. And the B2 bombers we have, you know, the B2 who went to Iran to go and do. The B2 bombers we have are the vaccines at this point. Our screening structures and services are not as strong. So we need to get the vaccines through. So use every opportunity anywhere in the health facility that any teenager is coming for any service. Ask, have you had your cervical, the cancer vaccine? And then you go. Make sure that you refer them. Make sure that you remind them. This is very important. Courageous clinicians do this. Be a courageous clinician. As has been mentioned already, churches, monks, social media, and centers. Let's make sure that we know what we can recommend for them. And the last one, courageous Christians, clinicians, ask questions. This war is not for Ministry of Health, Ghana Health Service, GPI alone. we need to ask them questions. When there are no vaccines, we need to make sure that we are getting every girl getting the vaccine. There is, because I've been working in the development, there is a certain level of inertia in our system where hierarchical constraints, people don't speak up, no, see no evil, say no evil, just live in the system. And I've done a lot of work within the development, engaging our system. Courageous clinicians don't do that. Ask the questions about the vaccines. Make sure that people can get it. Wherever the Minister of Health passes, and we've done this before, make sure that if things are not going well, you ask questions. That's the only thing that pushes them to make sure there are locations that will make us to have it become routine. Courageous clinicians. It's like I'm putting on my activist hat. But next slide. This is the last slide. Of healthcare workers, we have the power to make sure no girl grows up in our communities to hear those dreaded words, you have cervical cancer. We have the power because of the trust that parents have in us as healthcare workers. Thank you.
Thank you very much, sir. You could tell that he's very passionate about it. Very, very passionate. And if he had more time, I'm sure he would tell us a whole lot more. I hope we can still have access to him in terms of contacts and all that, because I'm sure quite a number of people would have questions to raise with him. The next speaker we have is Dr. Jacqueline Asibe. She's a senior specialist pediatrician, clinical coordinator at the Holy Family Hospital in Techiman. She's going to be talking to us about HPV vaccination and the role of parents, schools, and communities. Please let's welcome a pediatrician who saves lives and leadership inspires many. Thank you.
Thank you so much. I'm very grateful for the opportunity. The good thing about being the last presenter is that usually most of the work has been done. And most of the things I'm going to talk about is being done by the previous presenters. But I still believe it's important to reinforce messages. So we'll be looking at the role of the parents, schools, and communities in the introduction of the HPV vaccine. These are my outline. Okay. So the objective by the end of this presentation, we'll learn about the role of parents, schools, and communities in the introduction of the HPV vaccine in Ghana. So I think this has been emphasized already. Vaccination against the HPV vaccine is an effective primary strategy to prevent HPV-related illnesses like the genital warts and then the cancers we've been talking about, cervical cancer and the oropharyngeal cancers. School-based vaccination programs have an effective strategy for delivering the HPV vaccine to the girls because they are in the school. Where they go to school, that is where we'll give the vaccine. So school-based vaccination programs have been known to be very effective. So parents have a very important role, critical role in vaccine acceptance. They will give the consent, especially those they will give the consent, awareness, and then overcome the concerns of the children is very important. Schools supported by parents will ensure access because they will give us the infrastructure and the framework to give the vaccines. And then they will also support with education of the girl child. Community strengthen acceptance through awareness campaign and then positive social norms and the trusted voices in the communities will also support the introduction and then also the acceptance of the vaccine. We'll take each of them and look at their different roles. So the role of parents, consent and acceptance. Definitely, if the parents don't buy in, it will be difficult for them to bring their children. So the parents' knowledge and perceptions and approval are essential for obtaining consent for their child's vaccination. Very, very important. Parents need to understand the benefits of the vaccine and need safety to overcome misconceptions and ensure high coverage rate. If they accept and are well educated, they will definitely bring their girl child forward. Peer advocacy, they also have a role. Parents can advocate for the vaccine within their networks, influencing other parents and then promoting acceptance at the community level. So parents will need their consent and acceptance education, and then there will be advocates in the community for us. We'll look at the role of schools. So implementation of the program. So the schools are the ideal settings because the girls are in the school and we are using the school the vaccine. So definitely they provide the infrastructure and framework for us to give the vaccines to the children. Education and awareness. Schools can integrate this HPV vaccination into their health education curriculum so that the children are educated already even before they are exposed to being given the vaccine. And then the logical support that they'll provide the infrastructure to give the vaccines and improve to travel anyway, and then improve accessibility for the students and also for the family. We look at the role of the community. So public awareness campaign, I think Prof. NML and the previous speaker talked about it a lot. We need comprehensive education plans and community awareness, and that will promote understanding and then acceptance of the vaccine. We need to foster positive social norms in our community so that they will encourage vaccination, parents will buy in, and then the students themselves will also take it up. Health provider influence. I think the previous presenter has done a good work. Health providers, because we will provide, we are trusted or respected figures in the community. The correct education that we provide to the community will make the parents who accept and then buy into bringing the girls on board. Community engagement, so engaging with the community leaders. And for us, I think the previous presenter talked about, we have the queen mothers, the chiefs, all the opinion leaders. We need to bring them because they are very respected in the community. We can use local information and centers in the community because that is what most of the community people engage with, especially those at the rural settings. So we need to use all as a system to engage the community so that they buy into the vaccination and then it will increase acceptance. Okay, so these are just some few papers and that looked at vaccination, HPV vaccination in rural, this was in rural Nigeria. The study aim was to understand the challenges of school implementation of the HPV vaccine in a remote rural setting. And I believe Nigeria is very close to us, Ghana. So we look at the results. They realize the higher the education of the girl child, the more knowledgeable they knew about HPV vaccine and even also about cervical cancer. Parents gave consent, but affordability was a problem. We are blessed in Ghana, we'll get the vaccine free. And we are very grateful to UNICEF and all the other partners. There were some challenges, high operational costs and limited workforce and infrastructure. I think we talked about some of these, how to overcome these. The conclusion was that sociocultural perspectives are crucial to HPV vaccine. I think we've talked about it's very, very, very important. Addressing those issues will increase acceptance of and then take up of the vaccine. Effective communication, delivery, and advocacy will improve the relevance and acceptance. They realize that the school-based programs are very promising and successful, but will depend on careful planning and monitoring, addressing the operational costs in rural or hard-to-reach areas, and strengthening the workforce and infrastructure that will provide. Okay, so this also looked at parental and provider attitudes in the school-based HPV vaccine program. So what the aim was to determine parents and providers' attitudes towards school located provision entry requirements for HPV vaccination. The results were that most parents supported providing the vaccination in schools. Citing the reasons were it was convenient where the child has a school, that is where they get it. It improved access and then a positive peer pressure. Those who oppose where there were just raised concerns about privacy and then the capacity of the school nurses to manage the vaccine-related reactions. And I believe all this will address before we start the program. Okay, so this also looked at knowledge and intention to vaccinate their girl child. They realized that the more knowledgeable the parents, the more likely they'll buy in and then bring their girl child on board. So there was a strong link between parental knowledge and then vaccination intent. So the recommendation from this study was to integrate HPV vaccination in routine health service, which I believe after the initial rollout, it will be in our systems and be routine, part of the routine vaccination program. Okay, so in conclusion, I believe a collaborative effort between the healthcare system and community through effective communication, education, and a safe process for the introduction is essential in the introduction and acceptance of the HPV vaccine. These are my references. I truly believe if the health system collaborates together with the community, the schools, and the parents will have a successful introduction and acceptance of HPV vaccine. I believe it's very possible. Thank you. I'm grateful for the opportunity.
Thank you very much, Jacqueline. Okay, just a little announcement, please. There will be an evaluation form that will be shared both on Zoom and on YouTube live streaming. We have record numbers of people who are attending the Zoom link. I think over 3,000 people so far have joined. Am I right, Gabby? Have registered over 3,000. Wow. The only pediatrician in Ghana, you've done well. So please, because of some challenges with capturing professional pins, there'll be an evaluation form. It will assist us capture those pins for free CPD credits. So please look out for the evaluation form. And very quickly, I'm going to call back Dr. Selam to give us the viewpoint in terms of building a future free from cervical cancer, national strategies, and global commitments on the HPV vaccination. After that, we're going to have our questions and answers. So please, if you have any questions, just jot them down. You can send questions via the Zoom link, via YouTube as well, and these will be addressed. So Salam, we know already how you speak, so yeah.
As the truly final presentation, quite a lot of what I have on my slides will be skipped along. So please, you can start sharing. So that's my slide. I was going to talk a bit about cervical cancer, talk about other things, but we'll do skip. Please skip. And skip. And skip. Okay, so I'll start from here. So I think that Dr. Braka already spoke about this. The global burden, we've spoken about what is happening, we've spoken about what we intend to do, and we want to talk about the fact that cervical cancer is in fact very preventable. I don't know how many cancers are as preventable as cervical cancer. I know this other one, gastric cancer, is also infectious, but there's no vaccine against that. Cervical cancer is the true one that we know that with a vaccine, we can actually prevent women from getting it. And vaccination goes to screening, but let's be real. How many women here, let me take a small poll. over 35 have had a pap smear in the last year. I'm seeing prominent hands down. So you see why we are looking at vaccination and not screening. Because if we say screening, now adults like myself, I have work. What time am I going to leave my work and go and sit down and be in a queue and then wait for my test results? You see how it is, when you become an adult, your problems multiply. That is why we are looking at, for us, vaccination being the easier way. Because once we get our girls and they take the vaccine, at least to a larger extent, we can close our eyes and go to bed. I'm saying larger extent because still, as you know, the vaccine is about 70% effective. So there are some people who may still go on to develop the cervical cancer, but it's a very minimal number, which is why after the vaccination, we expect that when you get to the right age, 35 and the rest, you still go ahead and get the screening. But even if you don't screen, we know that most girls after vaccination would not have cervical cancer. Please move along. Please, let's move along again. Dr. Ghani has spoken about this. Please, let's move along again. So let's look at this map. I like this map. Do you know why? We are saying that if we don't do something about cervical cancer and we don't start the vaccination, you see those of us in red, we are the most miserable lot. We don't have the money. We don't have the hospitals. Our doctors are leaving. In fact, doctors and nurses and everybody is leaving en masse to the blue areas. And then we are here. If we don't do something, our cervical cancer cases would increase fourfold. If we just leave things, if we do status quo, we are just there and we are just going as usual. So it's very, very important. Let's look at this map. Me, I'm in this map. Every woman in this room is in this map. Unless, of course, you've done hysterectomy and done the total. I mean, that's the one, total, and taking the cervix out. If not, every woman here is in the red. So we have to do something. Look at our girls. Do we want them to grow up and also join the red? No. We want to create a better life for them. So if we do not start the vaccination, this is where we are going. And it's a very serious place to be because our health system is already constrained. Dr. Ghani spoke about women with cervical cancer. It takes me back to house job. I did it in Kolebu, the almighty Chinad. Those who know Chinad, remember, when you enter, what meets you? The scent. And the women, you see that the way they feel so low. I can imagine the mental thing. You are lying there and you are having a very offensive discharge. You are there and they are spraying, the nurse to come around, and they'll spray. Or they'll say you should buy Zuflora, and then they'll drip it around you. I can't imagine lying there and feeling like that. Even that will kill me faster than even the cervical cancer, the whole mental thing. So this is something we should look at. If you don't remember anything, look at this map. Red. We don't want to continue red for our girls. Please continue. So this strategy we all know, 90, 70, 90. I had done some additional slides, but we'll just leave it as this. We want to make sure that we are vaccinating 90% of our girls by age 15. And you know why we chose 9 years for us in Ghana? Does anybody know why? Because somebody was asking me, why don't we do it 15? Why aren't 17-year-olds vaccinated? Do we know why we are doing 9? Somebody said yes. Who said yes? Please, you can answer. Yes, our girls, even though we choose to deny it because we are overly religious, our girls are having sexual debut at earlier and earlier ages. And this vaccine is most effective before sexual debut or before exposure. So we are choosing 9 years, which seems quite low. But the reality is that if you go into the communities, we public health people, we see them, they are having sex. They are living with their boyfriends. It's hilarious, but it's true. Those who go into the community, you know. We want to make sure we vaccinate our girls. As for the screening, you see, even this room, 70% have not screened. So you can imagine if we are doing screening as our major intervention for cervical cancer, we won't get anywhere. Treatment to the gynae oncs, how many are you? 10. Less than 10. The whole Ghana, from Hamile up to Axim, you have less than 10 gynae oncologists. So what is happening? When you are sick, you are going to be on a queue. Radiotherapy, right now, I don't know if Kolebus machine is working. You are in queue. So you end up developing complications whilst you are going. So Ghana, that is for us, 90% vaccination. Please move along. So look at the countries. You see, do you remember that red map? You see why the others is blue. People have introduced this. Even our noisy neighbors, you know those noisy neighbors, the Nigerians, those noisy neighbors, they have also introduced it. Even though I would say the coverages may not be the best, but it's available. And that for us is more important because in Ghana, the vaccine has been here for 10 years or more. In fact, I want to mention any particular place, but there are places in this Accra that when you go and you do the HPV test, they offer you the vaccine. And it's very expensive. It's very expensive. A lot of us have not taken the vaccine because it's expensive. You see, but now the government of Ghana has sat down and thought that it's very important that we commit our resources. It's an investment into the future of the country. It's not just giving them, protecting them by themselves. Because the girl with cervical cancer or the woman with cervical cancer cannot go to market. Don't forget to have an impact on her children because she'll be able to take care of the children. Those children may drop out if she passes, if she dies. So it's a very important, it's a business decision for this country that when we vaccinate our girls, they will be alive. They will contribute to the economy. They will contribute to making sure the next generation stays alive. So we are there. As for the Nigerians, they are in the corner there. They're also doing their thing. Cote d'Ivoire has also done it. So has who? Burkina, Sahel country. And we are, Ghana is there. See us right there in the corner there. So it's very important that we start it and we start now. Please move along. Please, let's skip all these slides. I won't focus on any of all this. I want us to look at it. So now I want to talk about the pilots. I mentioned that we've had this vaccine in country for more than 10 years. And in fact, quite a number of pilots have been done. And these were done to assess how feasible it will be, how acceptable it will be. We're looking at side effect profile and all those things. In fact, other work have been done, but this is not for us. They've done economic evaluation, you know, the usual academic stuff. Those ones that feed into the policy for what the ministry would go and make a case that government should fund. That one I can't share. But this one is work that we can know about. So in 2013, there were 13 selected districts in the country that did a study, and they used Gardasil 4, which we are coming to use now. And it was done in 13 districts, 17 in central, 6 in northern. And then we use what we call a school-based, grade-based approach. So we picked the grade. We said class 4 or 5 with a few girls in class 3. And then we had 80% of the girls being enrolled. So we did a 3-dose regimen. And you notice that first time we went, 94.4% of the girls came. By the second time, you see what has happened here? 89.8. Some of them didn't come back. By the third one, 76.7. Which means that when you have longer dose schedules, there's dropouts. It is a natural thing. So you know when you have, compared to a 1 dose, it's one and done. You come, you take it, and you go. So this was something we did. And we found that with the side effects, they were the usual mild ones. Fever, headache, side pain. Those of us who take injections and have pain in our arm, it's normal. Pain in the side, some abdominal pain. But we found that generally the safety profile was very good. And we have a video of some of the girls from these pilots. We'll share them later. But those who did it, they are still there. Nobody has said they are having issues with their fertility or anything. The girls are alive and well. Please move on. So we had another study, also in Greater Accra in the northern region. And they had 2 districts. They had 2 phases. So we are looking at using a 3-dose regimen and then a 2-dose regimen. And this was funded by Gavi. the same people who are supporting us to roll out the vaccination. In fact, they support all our vaccination. We should clap for them because they pay a significant chunk of our vaccine cost in Ghana. So Gavi sponsored this and said, let's look at, we want to do 2-phase or 3-phase. And then we did the 2-phase, people finished in November 2017, and the 2-phase were in May 2014. Please move on. So for the phase 1, which was only in school girls, we also chose stage 4, which was a grade-based approach. And as you see, as it goes down, the girls are reducing again. And then phase 2, which was a 2-dose one, we looked at in-school girls and out-of-school girls, because most of our girls, looking at the way we have free education now, most of the 9 to 14 girls would be in school. Of course, you find a few of them out of school, but they tend to cluster in places like the markets and things where they are headquarters and things. But most of our girls will be in school. And you see, by the time you move from the first to the second, look, some people have dropped out again. So then we realized with an independent evaluation that 81% of the girls in that target group had been fully vaccinated. Of course, it could be higher, but this was a small pilot because we didn't want to do a lot, because with the pilots, you have to regulate the people coming in and things like that. Please move on. And for this pilot, we had our first lady. This was the Dodoa in 2013. She launched the pilot. I remember there was so much pomp and pageantry. I was then an MO in that place. And I was wondering when, after the pilot, the rollout will come. It's been, I know, right? It's I was an MO when she came to launch this in Dodoa. And what, 12 years down the line, we are now coming to do a full nationwide launch. And this is strange, it's taken 12 years, something that other countries have had in their immunization schedules for more than 12 years. We are now here. Please move along. So what do we intend to do? We've already mentioned that we are starting this on the 7th of October. It's a Tuesday. And we'll do our launch on that day. And that very day, the facilities or the districts will start their work. So they will start work in the morning, having already gone to the schools to pre-arrange. So what we've learned from one of the pilots is that before you go and do the immunization, you should have gone and registered the girls. So you know that I'm coming to a facility or coming to a school, I'm coming to immunize 20 girls. So as you are coming, I'm prepared with your list of 20 girls, you come and immunize them and you go. So they would have done all that. And like our school health immunizations would have made the schedule. Someone have a schedule. Today we'll go to international school, community school, whatever. You know the schools and the times you give them. Would have done all that already. And then we'll be using age-based. We've stopped the grade-based because sometimes we have class 3 mommy. Those of us who are a bit older and went to government schools, you remember class 4 papa and class 3 mommy. Girls who are much older than our target group in the lower classes. So now we say 9 to 14 years for the campaign. And we are using the quadrivalent Gardasil, which is going to target 16 HPV strains, 16, 18, and then we've sprinkled on 6 and 11 for genital warts. So even though we are not talking about that one, what we are giving will also target genital warts. And then we are giving a single dose. And we are, as I said, it's a multi-age cohort. We are expecting to immunize about almost 2.5 million girls in the campaign, so, which is why we need all of us to be on board. Unfortunately, we have so many health workers, there's no avenue to meet everybody. But this is a chance for us to know what we are coming to do. Those who work within the public system, trainings are going to be cascaded down, you have them. But for those who may be outside or may not hear too much of what is going on, this is what we are going to do. After the campaign, we are going to do routinization. So it's going to become part of our routine vaccines. So if you walk into any facility, public health facility that offers vaccines, you can go and get it. That is after the campaign. And we are going to catch up the 10 to 40-year-olds for a while, because after the campaign, we know that the bulk of that group would have been vaccinated, but a few would continue coming for some time. After a while, all those people would have been caught up and they will face and stick to the 9-year group. And we are using age-based in school and out of school. And we are using our normal methods. So we'll do outreaches, static points, which is at the health facilities, what we call camp out, where I'm sure you've seen pictures and videos of EPI staff putting things on motorbikes, entering into corners on boats and things. They move out into island communities, hard to reach areas. We'll go and camp out, immunize them, and then we'll come back. Please move along. So, I'm sure some people are wondering why, after all the studies I showed you, we are looking at a single dose regimen, because some people do 2 doses, some people do 3 doses. We've reviewed some literature, and we found that the single dose is effective against the cervical cancer. We've also found that compared to the multi-dose regimen, it demonstrates a similar efficacy. So currently, based on the literature we have, there's no need to go and do more than 1 dose, where you end up with some of the girls getting off anyway, when the 1 dose is enough for us. And currently, looking at the literature or the data available, we don't have any need for boosters. So once it's one, as I said, 1 and done, you immunize and then you go. The next slide has some of the studies. We'll share the slides so that you can take your time and look through. But what we are doing is not done haphazardly. It's something we have done based on literature and based on research. We believe that all of us here will join hands and help us push this idea to the population. Please move along. Those are studies. Please move along. Please, you skip this slide. So I think I'm tying up everything everybody said. We are saying that the burden of cervical cancer is on the increase, and also the way it goes, mortality is also going to increase. And it's feasible for us to eliminate cervical cancer, at least in Ghana here, with the use of the vaccination in addition to the other interventions. Ghana has done pilots successfully, and we've demonstrated that it is feasible to have high vaccine uptake. And we've also demonstrated that it's a very safe vaccine. Let me add that, which is not on the slide. We are going to introduce a vaccination on the 7th of October. We've done so much work, micro-planning, advocacy, etc. But we are counting on everyone here to join us to be able to implement this. EPI program sitting in one place in Kolebu cannot do this. Everybody here has a role. When people come to you and they say they are coming to immunize my daughter, what do you think? You should be able to give them good, solid education and help to dispel the myths. Because what we found is that it's our health workers sometimes don't have adequate information. They're not able to convince or inform parents about the benefits of some of the interventions. So it's important that all of us know what we are going to do, know the benefits, and then we'll all have at least 90% of our girls by age 15 being fully vaccinated against HPV. Please move on. This is some of the work we did previously. Please move on. Thank you. And these are our partners. In fact, some partners are also not here, and they have asked that we put their logos inside. But these are our traditional partners. If you see PSG is looking at me, they should have been here. Thank you very much.
So now you saw the real person. Thank you so much for your presentation. So now we know what the strategy is. We are better informed. Thank you so much. Again, I want to quickly make this announcement again. An evaluation form is to be put up on the Zoom link, as well as the YouTube live streaming link. Please fill those forms, because especially for those on the YouTube link, we haven't been able to capture your MDC, your PIN, professional numbers, PINs. So please, we do not want to miss anyone. The CPDs is free. We don't want to miss you. So please just fill that evaluation form so that that can be captured. Again, for in-person participants, don't go anywhere. We are almost done. We're just going to have Q&A, the traditional closing prayer. Then we go and eat. So please, I can see Amma is eager to go and eat. Yes, so please. So please, dinner is ready and will be served right after we finish this program. Presido, isn't it? Yes. Yes. I want to throw this out now again because it was quite disheartening to find out that quite a number of our females haven't had screening. It's key, please. So next time we have another PSG meeting, Presido, you do a roll call, isn't it? To make sure that our females have at least taken the step to go and do screening. You know me, I can push it. I'll start taking pictures. All right, thank you very much. Now we're going to have our Q&A session. We're going to have our Q&A session. We already have some questions online. Gabby, are you ready to start us on the questions? So let's just quickly start with a few questions from those online. And again, I want to say a big thank you to all our online participants. Without you, this wouldn't have been as widespread as it is. We're grateful. Wherever you are, please give yourself a round of applause. And can we all in persons give online participants a big round of applause? Yes. Gabby, are we ready?
Yes, we are. Okay, so
all right, yes.
First question in the chat here. Since HPV is transmitted through sex, does it mean that men have it? If yes, why men too are not, why are men not protected, since the women will surely have sex and with men, so the transmission will continue? So I think this question was answered already, but yes. I don't know if, yes.
Let's take about 3 questions, put them together, yes. Okay, so teenagers in that age group, 9 to 14 years, who are pregnant, can they take the vaccine? Okay, that's one. Wow. Okay, when boys can take the vaccine, okay. And last one.
Infection. Governments putting in place to support individuals who may have already been exposed to the HPV virus before receiving the vaccine?
Okay, so I think all those are to Salem. Oh yeah, about policy, the program.
So those who have been exposed, you can ask him. He's a policy man from the government. Okay. So he will tell us about the other one. Okay, so I'll talk about the boys. So the boys can take it from 9 years. Currently, some people are giving it to their sons. They go and pay for it. Our program currently, or the way the vaccine thing was done, we are targeting cervical cancer. So women are the primary recipients. But we know that even when we vaccinate the girls, the boys will secondarily be protected. So currently we are looking at girls, but we have approval to do boys and girls. But as our system becomes more robust, I'm talking politically, we'll be able to expand to the boys as well. The pregnant teens, no, we won't give any pregnant teen. It's when you are, in fact, Ghana's program for giving immunizations in pregnancy, the only vaccines that have been cleared to be given to pregnant women are COVID vaccine and then TD, that's tetanus diphtheria. That's all. We don't give any other thing to pregnant people. Thank you. And then the government, what is government going to do for those already exposed? I think that one will defer to the Ministry of Health.
Salom. Your government. So those who are already exposed. I think just like you mentioned, if somebody is pregnant, I think the idea is to reach out to, the girls between 9 years and 14. The intention is that they wouldn't have been exposed. But if somebody is already exposed, then I do not think that you will need the vaccine. Similarly, when you talked about the fact that a pregnant woman or a pregnant girl, then that pregnant girl has already been exposed. And after the delivery, you also be screened to find out what stage that you find yourself. So basically that is it. Yeah.
So I want to add something, since I put him on the spot. So there's actually a screening protocol. The Ghana Health Service has developed an HPV screening protocol for cervical cancer. In fact, it was done in partnership with the WHO. I'm not sure how well that has been disseminated, but screening is available in a lot of the facilities. The challenge, however, is the cost, because it's not currently under any health insurance scheme. So there's a policy guideline on it, but as to the implementation, that is where there's a bit of a challenge. Thank you.
Thank you very much. Thank you very much. Can we please have, oh, don't worry, hold on, relax. I know you have questions. Can we have our presenters, please? Yes, they want to see your faces. All right, so our presenters, please, all our presenters, come to the front. We can start without the professor. Okay, so now we're going to take 3 questions, in-person questions. Oh, wow. All right, so what? 3 questions. So 3 questions in person, please. We'll take the 3 together.
Okay, thank you so much. So my question is concerning the 35 to 45 years old. I think that was what the online person was trying to ask. It's not about the exposure to the HPV, but then it has to do with what if you are sexually active, you are out of that age bracket, which is the 9 to 14 years, 15, 16, 17. In other countries, you can take the vaccine from ages 35 to 45, which is the woman. But then since the immunization is just based on 9 to 14, meaning those are out of that bracket, we have to pay for it, which is expensive. So are there measures being put in place that we are all entitled to taking the vaccine regardless of the exposure? Because if you are exposed, you can have pre-cancer cells, which is in between developing into cancerous cells or not developing into it. So even though you've been exposed, the vaccination can in a way help to prevent other HPV variants. So that's what I want to know about. Are there measures in place? Thank you.
All right. Thanks to all the presenters.
I have to call you.
Oh, sorry. Right. PM, after the introduction, when it comes to the routine, when is that going to be? Is it going to be immediate, or we have to give us some months, or when? Thank you.
Thank you very much. One more? Any? No? Okay. Okay.
So let me also join others to thank the presenters for the excellent presentation. My question to the first presenter that spoke about the burden of the cervical cancer. And from your experience, because you are into oncology, looking at the population of Ghana with less than 10 doctors who are into oncology, what is making that subspecialty less appealing to doctors, especially looking at the burden of this disease? And then the presenter that spoke about myths and all of that, in other geographies, we've seen where medical doctors allow their religious belief to overcloud their understanding of science. And because of that, they form a group of people who refuse to take the vaccines and even encourage their clients to accept vaccines generally. Now, what is the position of perhaps Ghana Medical and Dental Council over such kind of individual doctors who they themselves don't accept vaccines and discourage their client from accepting vaccination? Thank you.
Who wants to go first?
Well, thank you for the question. If I got you right, you want to know why Ghanaian oncology is not so appealing, or why we don't have a big number of Ghanaian oncologists in the country. So traditionally we were, yes, okay. So we have two colleges that train OBGYNs in Ghana. We have the West African College and the Ghana College. Currently, the West African College does not offer subspecialty training in Ghanaian oncology, leaving the Ghana College. Ghana College has so far trained 2 Ghanaian oncologists and is in the process of training about 10 more. So there are about 10 Ghanaian oncologists or fellow Ghanaian oncologists in training. Others have gone outside the country, and we're expecting them to come back and help the women of Ghana.
So I'm answering the question of those who are outside the age group. Unfortunately, the vaccines we have procured belong to the target age group we have given. So if we start to open it up and say everybody else should vaccinate, our children will be left out. So we want to push that for the children. So those outside that target age group, we advise that the parents should, you can get the same vaccine in the private sector. It's a bit expensive. It is expensive, but the reality is that the way the program has been structured, if we leave it open, we'll lose the people that we actually target, because a lot of that age group you are talking about may have already been exposed. A lot of them would have already had sexual debut. They may have had a vaccine, they may have had a virus prior. So the greatest benefit is for the group that we selected, and was selected based on that argument. So unfortunately, we cannot open it to, for now, to that group, or even the 35 to 45 group. That's also a very vulnerable group, but we're unable to do that.
So on the issue of the doctors who are hesitant, or they are within the group who are anti-vaccine group, well, vaccination is a national policy. And so if you speak out against vaccines, there are disciplinary code, which Medical and Dental Council, when it comes to their attention, you'll be called to justify why you're advocating against the national policy. So there are laws to that. Yeah.
I just want to contribute to this question about those outside the program. I mean, as the PM said, the program is focused on 9 to 14. Within that period, the response when you give the vaccine is the highest. And we are focusing on cervical cancer. So that is what we can afford. That is what we can do for now. But as I mentioned, we need to know that outside this, if you have the resources and you want to have the vaccine in the private sector, you go in for it. Let us not close our minds. What we can do is what the government is able to do to protect our most precious against cervical cancer. In some countries, and let's open our minds, read about the Cameroon program. It's a gender-neutral program. They decided to go for both boys and girls because of some other reasons. Let's know what our government can do, what the limit is, and what the program is doing. And let's know what is possible, so that if we need to do that for our boys. When you look at the 6 cancers, oropharyngeal cancers is second to cervical cancer when you look at the HPV cancers, the 6. And in some countries, the pediatric physicians who look for the chest physicians, because of recurrent respiratory papillomatosis, they are the strongest voices in some of the countries that have happened to us. So let's be open as healthcare. Let's know what the science is. And so when somebody has his money and wants to do it in the private sector, we do that. And we push as things go on for the private sector prices to also go down. But let's focus on what government can do, and for now, what we have for Gardasil 4, and make sure that every girl within this cohort, within the period, PM, how many weeks is it going to be for the campaign?
It's 5 days.
5 days. Yeah. The 5 days. Let's make sure that as much as possible, that is the, but remember, it's not close to them. 9 to 26, you can have it. As was mentioned, 26 to 45, you can, based on conversations with the doctor. If you have the resources you want to protect yourself, do that. Sometimes the private sector is just 2 pieces. 2 pieces. I know, but what I'm saying is, so let's make this program for 9 to 14 successful, every girl. But those outside, if they can have it in the private sector, we make sure that they get it.
I think I missed the question about the routinization. Yes. Immediately we are done, we are ready for routinization. We have the vaccines for the routine already in country. So there's nothing like shortage. The vaccines are in country, campaign, routine, everything is available. So all we need to do is just go in and take the vaccine. Thank you.
And she's speaking because she knows. Yes, I would also want to quickly add that even though it's in a private sector, in Kolibo, you can get it. Kolibo is a public facility. You can get the vaccine in Kolibo at a cheaper price. Yes. So,
can I add to-
so it's not just a private, you can get that. Yeah, please go ahead.
Let's not forget that it's a 3-pronged approach to eliminate cervical cancer. Primary prevention is HPV vaccination. The secondary prevention that includes the screening. So we do need to get screened. Even after you have the vaccine, you need to get screened. So women or girls outside that age, after age 21 years, you should start having your regular screens with pap smear or liquid-based cytology or HPV DNA. And then if you have a precancerous lesion that will pick up, you can be treated and it doesn't develop into cancer. So even though you do not get the vaccine, it does not mean that you're going to get cancer or a precancerous lesion. You must continue with the screening.
Thank you very much. We're going to have 3 questions from online before we come back to in-person, and then we'll wrap it up.
Okay, so from YouTube, there are a couple of questions here. Please, are there any contraindications identified or any adolescent young woman at all is eligible? And then another question is, can any girl just simply walk into the hospital to have the vaccine, and or the vaccinators will come to the girls? And then last question is, what about those who don't know their age? Is there a way to go about determining who falls within the eligible category?
I believe all those questions are for Salom. Yes.
I was just telling him most of the questions will come to me because it's mostly operations. Okay, so with the campaign period, we'll be going to the schools. As we know, the majority of the girls in that age group are in schools. So we'll go to them. Then on Saturday, we'll focus on the out of school girls. And in fact, in some places, they might even do Sunday, looking at the dynamics. Because if you have a lot of head porters, it's only Sunday you get them. That is what we'll do for that. So for the campaign, we'll come to you. However, if you are by a public facility, you can also walk in. There's nothing that binds you to be taking it in school, because we know that despite our education, some schools will still not agree for the vaccination to be done in their premises, which is why we have it available at the public facilities also. So you can walk in there and take the vaccine. And then there was another question of contraindication, pregnancy, and a girl who is seriously sick, or somebody who has previously had allergic reaction to HPV vaccine, which is normally, it's not something we usually find, but those two are the primary things that we don't give to. And then for those who don't know their age, that's when our staff are trained to be able to have an idea of the age range which the person will fall into. So we will be fine with that. If you are in school, surely you will have an age, because your school would have something written there as date of birth. This question is mostly to those out of school, but typically on engagement with them and with their caregivers or their guardians and the rest, you can have an idea of what age range it is. So they can still take the vaccine if we find that they are in the same age range. Thank you.
Thank you. So we're going to have one question from this table. This table, you have a question, and then over there. Yeah. So who wants to ask the question?
Yeah, Mr. NC, I think I have to say this before I go to my question. We are from the Ghana Federation of Traditional Medicine Practitioners Association, GAFTRAM. But when we came out, I think we were not acknowledged when our sister associations were acknowledged. But I'm talking about my own. I'm talking for myself, not for somebody. So let's go to my point. My questions goes to the last presenter, Madam Salom, Dr. Salom. Yeah, you talk about the first pilot and the second pilot. You talk about the first pilot. When you came the second time, the attendance of the girls was low. May I know, you found out what counts before the attendance came low? And second one is a suggestion. I want to suggest that, these days, there's no way we can eliminate the herbal daughters in this program. I would advise, if it will be possible, this advocate to include the herbal daughters so that they can also dispensate these vaccines. If possible, if you can make the vaccine as a drinkable one, to avoid the injection, that can also help us. Thank you very much.
Thank you very much. Thank you very much. I will duly acknowledge your association. Thank you.
Thank you very much. I think we all keep saying that the vaccine is a bit expensive. Please, may I know how much it costs? Thank you.
Okay. Yeah, go ahead.
Good evening. Dr. Boy, I'm sure you were hoping I wouldn't speak, but I'm going to speak. And I just wanted to say that, yes, there are probably 10 Ghanaian oncologists, but there are clinical oncologists in the country. There are over 22 of us. Yes, we have a few issues, but we are here and we are important in the treatment of cervical cancer. That's why, even though we weren't invited, we've come ourselves to let you know that eventually the buck will stop with us. And the patients who eventually develop the cervical cancer will come to us. That's why we are here. I also wanted to make a comment about the
traditional group, the traditional healers group, herbal.
Traditional medicine.
Traditional medicine, correct. And I wanted to say that we recognize that you are very important, especially in the management of chronic diseases. And for cancer, we are really interested in partnering with you. So whenever it's possible, reach out to our center and all the cancer organizations so that we can partner with you. We know our patients come to you, so it's better we partner. Thank you.
Thank you. So, Salam, do you want to start?
So I'll start with the issue of the vaccine, the drinkable vaccine. Unfortunately, the way this vaccine is, it's not drinkable. It can only be an injection. So for now, we are doing that. And I'm very happy PSG. In fact, let me take credit. I asked PSG to invite you because I told them that if we are doing anything with health, GAFTRAM has to be part. Your leader, Nana Obriyeboa, he's my friend. So I mentioned that it's very important we have you. And you coming here and coming to see what we are talking about. When you have your meetings, I know you have so many smaller groups. GAFTRAM can meet them. If you want us to come and talk to them, you let us know. Your meeting at Art Center, if you are having, just let us know. We'll come and talk to your people about it because it's quite important. Unfortunately, it's not in the way that you can dispense. But when people come and talk to you about it, you can also go ahead and explain that it's very safe. We've had it in the country for so many years. With the issue of the dropping out, it's normal with anything that has multiple doses. You know that even the chronic illness, that's the reason why they don't like coming after a while. You take it for a while, you get tired. And this one, you are saying 3 times. By the next dose, some of those girls have stopped school. Some have moved out. Some may be, some may be pregnant. So they'll not be available for the next group. As you move along again, that group again, some will come out. So the dropping out is a normal phenomenon with things that are in multiple series, which is part of the reasons we considered to make sure it was just a one and done thing. So that we wouldn't have a situation whereby we are going around chasing people. Please, you remember COVID vaccination? When they gave the first one, by the second one, people were tired. Now we were public health people were going around chasing people to take the second dose. When the first one, they were chasing us for the first dose. By the second dose, they were not coming again. Yeah. So that's why we are doing the one. Thank you.
Okay, thank you very much. I know there are so many questions. That's the importance of this. It tells us that this is a very important initiative. And I want us to give a loud applause to government, the Ministry of Health, for ensuring that our 9 to 14-year-olds get this for free. Someone asked about the price. It goes anywhere from 3,000 to 5,000 cedis. And that is expensive. So for government to push this is significant. Now we're going to give our presenters, dignitaries, a last word, so that it's something that we can take home with us. We're going to start with our own professor, a last word, and then we go down the list. Thank you.
Yes, thanks to everyone who came, both in person and online. We've been well educated. My last word is, let's go with the facts and let's share the facts. Thank you.
Yeah, thank you very much. I would say that, as they say, recognition, I'm representing different groups. I'm sure they will say, why has it not been mentioned? But like the PM said, everybody is involved. I represent the Society of Private Medical and Dental Practitioners, and then also the International Papillomavirus Society Ghana chapter, who has been doing a lot of advocacy work to support this. Let's all push these together. It's not just for the Ghana Health Service or the EPI, as the PM said. It's for everybody. Let's get everybody, every girl, vaccinated. Thank you.
Thank you so much. I believe the collaboration should continue between the healthcare system and the schools and the communities through strong advocacy and communication. With all this information, we need to go out and advocate more for this introduction to be successful with the increased acceptance rate. Thank you.
My only word is let's get our girls vaccinated. Let's get our girls vaccinated. There's a lot of benefit from the vaccine. Thank you.
Thank you. So please let's not forget vaccination, and in addition to vaccination, screening and treatment. Thank you.
I'll speak when I'm given the closing remarks. Thank you.
Thank you again. So just a few acknowledgements. And I'm going to start with the Ghana Federation of Traditional Medicine Practitioners. A round of applause to them. And there are several others. So we have SOGOG, EPI, the Ghana Medical Association, and we have the person of the General Secretary, Dr. Selim. Please a wave. Thank you. Selim. We have the MWAG, Women's Association of Ghana. Yes. See, I'm not part of that association, so. We have IPVS. We have the Ghana Association of Public Health Technical Officers. We have the Family Health Division of the Ghana Health Service. We have Ghana Education Service. We have Ministry of Health, Early Career Pharmacists, GRNMA, they gave us a word, Pediatric Nurses Society, Preventive Health Nurses Society of Ghana. We have our distinguished speakers and presenters. Please give them a round of applause. And we have ourselves. Give ourselves a round of applause. So we're going to invite the only pediatrician in Ghana to come and give us her closing remarks.
About cervical cancer and why it's important to vaccinate our children to help to prevent it. We've spoken about the healthcare professionals and the various roles that they have when it comes to HPV vaccination, because we all want to be able to support for the implementation to be successful. We've also spoken about the myths that are commonly spread about vaccinations and especially about HPV vaccination. Then we spoke about the roles of the schools and the community, the general public, in helping to ensure that this implementation of vaccination is successful. We have heard a lot, and I believe that everybody has picked a thing or two about what they can do to help make the rollout of the vaccination, HPV vaccination, successful. I must say that none of this would have been possible without our partners, the Ministry of Health, Ghana Health Service, especially the expanded program on immunization, then the SOGOG, Society of Obstetrician and Gynecologists of Ghana, and we have two gynae oncologists here, Dr. Amagani and my own Dr. Abloboy, sitting coolly at the back. Thank you for all you do. Then we also have the Ghana Medical Association. In fact, they've given us a big team. Today we have the Greater Accra branch executives ably representing here. And then we also have a few national executives, our General Secretary and Dr. Lomote, all here. She is also a pediatrician. And okay, so just to say that this seemed impossible at the beginning, but through the support of all of you and the various partners that have been mentioned, we've been able to pull it off. There will be an official thank you at the end, but I'd like to acknowledge the able support of the executives that I work with, both at the national level and at the branch level, as well as our staff. Gloria at the back, we fight a lot. That's not surprising. I may have OCD and ADHD combined. Anyway, and Kelvin and Gloria and Dorcas and Reginald, who all provide support to make this work possible. So thank you all so much and have a lovely evening. Online participants, we are very grateful for you joining us. Thank you. World Health Organization, Dr. Michael Roxon. This weekend, I don't think he slept together with the entire WHO. God bless you.
Oh, thank you. Thank you, the only pediatrician in Ghana. I'll keep saying that. All right, so all too soon, we are coming to the end. We're going to have a few announcements from the Secretary of the Pediatric Society of Ghana in the person of Dr. Gabriel Obeng-Cranton. But before that, food is ready. I'm sure we've been waiting for that. Amma, you've been waiting, isn't it? Yes. So food is ready. Does everyone have a yellow, is it yellow? Okay, do you have something with a meal card on it? Oh, whether it's yellow or white, the color is the same. Does everyone have? Yes, you are going to need that to have your dinner, please. So don't lose it, okay? But it's only for one meal. All right, so we'll have dinner. So that's number one. Number two, we're going to have pictures. Photo. Where are we going to have the pictures? Outside or inside? Outside. Okay. So as we are about to go for dinner, we would move in a procession to have our pictures. Then we go for dinner. So let's welcome Gabi to give us a few announcements and then we'll close.
Thank you very much, Dr. Obeng. So my president has said a lot already. Has thanked everyone. Those whose names were not mentioned, we thank you so much. Our senior members who joined us online, Prof. Goka, Dr. Vivian Pencil, everybody who joined us online, we say thank you. And we have been able to make this program come to fruition. So PSG, we are inviting everybody here to join the Pediatric Society of Ghana. We will share our membership form link online on Zoom and YouTube. Those who are here can also see any of us for the link and then join by filling the form. It's very easy. Our dues is a small amount per year. And once you're a PSG member, you would really enjoy being part of the advocacy drive for children in Ghana. Our society is a very active one. We still have a lot of activities lined up for the month of September. So aside this very important program, we tomorrow we have a webinar known as the World Patient Safety Day webinar. And our president will be one of the speakers at this webinar. We will share this, so that's the poster. You can scan the QR code and be part of this program as well. This month is for childhood cancer awareness. It's also for birth asphyxia awareness. And so we ask that you join us in this advocacy drive as we continue to shed light on all these ailments which affect our children in Ghana. So that's all I have for you for now. And thank you very much once again for joining us. We'll also share our social media handles online and yeah, here, so please subscribe and like us.
Okay, thank you very much. So to close, we started with a prayer. We're going to have a prayer, a closing prayer. Dr. Tracy Kwashi. Okay. She's small, so she takes small steps.
Shall we share a word of prayer? Our Father in heaven, we thank you so much for a successful workshop on HPV vaccination in Ghana. We pray in the name of Jesus that each one of us will be advocates for this vaccination to help reduce the prevalence of cervical cancer in Ghana. As we depart from here, we pray that you protect us, take us to our various destinations, bless our meal, and may your name be glorified in our lives in Jesus' name. Amen.
All right, so my name is Dr. William Obeng, your consultant MC with the swag. Thank you. So let's move we can move for the photographs now and then straight to dinner. Thank you.